I'm Pradesh. Oh, right. It always happens. Technology. Sweet. Okay, now I have to repeat myself, but that's fine. It's now being recorded. Kia ora, good day, good morning, everyone, and welcome to the first day of ALTA, and we'll start off with the PhD Symposium. I'm Pradesh, and I'll be chairing the PhD Symposium. We have 4 participants. Each participant, they are given 15 minutes to present, and followed by 3 minutes of question and answering session. And without further ado, I'd like to invite the first speaker, Hanna Pethani, and with the talk on improving care in clinical dentistry with natural language processing of electronic dental record. And Hanna, you can unmute yourself and share your screen.
Thanks, Pradesh. Can you guys hear me okay? Awesome, thank you. I'll just share my screen now. Can you guys see the slides okay?
Yep, and when you start speaking, I shall start timing. So ready whenever that you are.
Okay, thanks. Hi, everyone. I'm Hanna. I'm a first-year PhD student and a general dentist. Today, I wanted to talk to you about NLP in dentistry and how it might be used to improve care. This talk is probably going to be quite different from the other talks today, as my focus is on clinical NLP in dentistry, which is something that's never been done in Australia, and it's rare across the world anyway. I'm interested in sharing a clinical perspective of how NLP could be used and how it might be integrated into the clinical workflow. And before I forget, a huge thank you to the entire research team for their support and contributions in the project so far. The World Health Organization has just released this report last month on the global oral health status. The report highlights that oral diseases have been the most dominant condition since 1990. Even in high-income countries like Australia. Oral disease prevalence is ahead of neurological disorders like migraine, stroke, and dementia. It's also ahead of digestive disorders like gastroesophageal reflux, appendicitis, and chronic liver disease. So what's led to oral diseases becoming the top-ranked prevalent conditions? Well, some of the key drivers of prevalence are behavioural and social determinants of health. Oral diseases are often considered a social disease because they disproportionately affect the socially disadvantaged. Employment, housing, and living conditions are all examples of some very important social determinants of health. Behavioural risk factors like tobacco, alcohol, and sugar consumption are shared risk factors between oral health, cancer, cardiovascular disease, and diabetes, to name a few. Another very important driver of rising global prevalence is access to care and the quality of primary care. The Australian Council on Healthcare Standards publishes the Clinical Indicator Report every year, which serves to measure the quality of care delivered. The report contains benchmarking information for a broad range of medical specialties, not just oral health. So where do we find information about a patient's behavioural and social determinants of health? Most electronic dental record systems have a structured medical history that includes smoking status. And in public dental systems, structured data also captures living conditions, but there are some limitations here. This form doesn't capture details about a patient's exposure history to harmful substances like tobacco, alcohol, and sugar. We know that there's a strong dose-effect relationship. That is, the higher the dose of a harmful substance, the more severe its effect on a patient. The structured field only asks about current living conditions and allows just one option, but a patient's past can be indicative of their vulnerability, and a practitioner could make note of future risk based on their conversation during the encounter. There are other things that are generally missing from structured data, such as indications of socioeconomic status, social or community context, descriptions of signs and symptoms, details about procedures and complications. So whilst we have these structured fields, they have limited ability to capture the details and nuances about a patient that ultimately impact their care. NLP makes it possible to capture these details at scale. Here's a chart of the number of included studies in systematic reviews that explored NLP research using text and electronic medical records. We conducted a similar systematic review that explored NLP research using electronic dental records and found that compared to the work that's been done with EMRs, NLP research in dentistry is fairly limited. We wanted to find out specifically what was the clinical purpose, how did the NLP methods perform, what impact did they have on patient outcomes, and what was the quality of reporting. We screened almost 10,000 records and ultimately included 17 studies. I thought it was interesting that most of these studies were conducted at the same 2 to 3 institutions across the US and China, including the Indiana School of Dentistry, the Columbia University College of Dental Medicine, and the Peking University Hospital of Stomatology. We found that we could group the included studies into 2 categories: studies that applied existing NLP methods and studies that developed and evaluated their own NLP methods. And there was a complete disconnect between the 2 categories, meaning that the authors from either category didn't make any reference to researchers in the other. For studies that applied existing NLP methods, all of them applied a keyword-based search using the vendor-supplied search function. Clinical notes were being searched for information about post-op complications, dental reasons for emergency department visits, and identifying triggers for adverse events like airway obstruction or allergic reactions to dental materials. The studies that developed and evaluated NLP methods, most of them focused on document classification. Some of the clinical use cases included classifying smoking status and intensity, cardiovascular disease type and severity, and extracting the results of clinical examination findings and tests. Some of the studies developed NLP methods as a precursor to developing clinical decision support systems. For example, to help clinicians decide whether or not to extract a tooth or assist in designing removable partial dentures. We looked at the quality of reporting for studies that developed and evaluated NLP methods, and overall we found there's a need for further improvement. Often there was no mention of vocabulary size or average length of the clinical notes, which might be useful to know to understand how this might vary across institutions and how it might impact NLP performance. We also struggled to find information about the environment, tools, or libraries that were used, and often the methodology was unclear. And whilst I don't expect to see institutional data sets being shared, this does show that in dentistry, unlike medicine, sharing de-identified data sets containing clinical notes hasn't been developed yet. Creating de-identified data sets that contain clinical notes is actually really hard. It would need to go through a rigorous ethical process to meet the requirements for waiving patient consent. You'd have to ensure there's no personally identifiable information in any of the notes. And under health privacy laws, you'd have to make sure that, to quote, "It must be extremely difficult, if not impossible, to re-identify an individual in this data set." These are some of the areas and ways I think using clinical notes could be very useful in addressing oral disease prevalence. I'm not going to read over these, but I will say that I deliberately left a question mark in clinical decision support because I'm not entirely convinced about it as a use case in dentistry. As a clinician, I can tell you that the more patients you see and the more experienced you become, it's hard to describe all of the factors that go into decision-making. I think some of it could be subtle cues during the patient encounter. So let's take that tooth extraction CDS system as an example. I couldn't in good faith rely on a CDS to help me decide whether extracting a tooth was in the best interest of a patient. There are so many factors that aren't being used as inputs, including psychosocial factors or financial circumstances, and some of these are non-verbal cues that are never recorded in the notes. So this is an example of structured output from extracting social determinants of health using a rule-based approach. Here we're looking at behavioral risk factors such as sugar and methamphetamine use, For each of the behavioural risk factors, though, we want to know more than the presence of exposure. Aside from a dose-effect relationship, there's also evidence that there are other factors impacting severity of effect on a patient. For example, sticky types of sugars, like lollies and chocolates, are more likely to cause decay because they retain on the tooth surface longer. Similarly, smoking 20 cigarettes a day for 30 years is likely to be more harmful than smoking 5 cigarettes a day for 5 years. We've also extracted employment status, housing status, and housing type here. In the structured data field, you'll recall that the practitioner could only enter information about current living conditions. There was no way of knowing what the patient's past living circumstances were or what their future risk might be. What we'd want to be able to do is synthesize the status, type, dose, frequency, and duration for each substance to derive a risk category. So I'd want to be able to say, okay, this patient's been drinking a litre of juice a day, but have they been doing it for 3 months or 5 years? The challenge is that the notes often don't contain enough detail for risk stratification. For example, here you can see the duration of a substance exposure is missing most of the time. And in the third row, this patient admits to drinking soft drink daily, but is it the sugar-free version or the full sugar version? That's going to change their risk category. Ideally, we would transform the extracted data and join it to the patient record to make observations about outcomes. Let's look at these 8 patients from 2018-19 and follow their journey. We're particularly interested in the high-risk patients. So we've got a 5-year-old patient with a high decay risk because of their high sugar consumption. We've got a 65-year-old male who is a heavy tobacco user. And then we've got 3 20 to 30-year-olds who have a history of homelessness. 2 of these patients also have a history of exposure to methamphetamine use. When we look at their visits in subsequent years, this is what we discover. The 5-year-old has had 6 monthly visits until COVID hit, and then he wasn't seen for 2 years. He's required a lot of treatment, including to his permanent teeth, which tells me he's going to need further work as an adult because those fillings will eventually break down. At his most recent checkup, though, at 9 years, there was no record of an updated diet history. Having an updated diet history would have helped keep his risk category up to date. The 65-year-old heavy chain smoker, 2 years later, it was recorded that he was referred from a detox unit that wanted to get his teeth assessed before they discharged him, but there was no information about what he was detoxing from. At his most recent visit this year, there was also no record of oral cancer screening, which is a requirement for every patient at every appointment, particularly for patients with a high risk of oral cancer. This is the sort of information representation that gets me thinking whether we should have at least advised this patient to return every 2 years for an oral cancer screening, given his risk. What's the cost of returning for a screening every 2 years for 10 years versus late-stage diagnosis and treatment? And the 3 patients who have a history of homelessness, only one of them returned for further treatment. She also had a caseworker. We don't know what happened to the other 2 patients. Did they move? If we had interoperable records, we'd know that, but that's a whole separate issue. Did they relapse? Did they have caseworkers? Should we have known that? Should we have referred them to social workers back in 2018? And based on their oral condition, these patients are the ones who are most likely to make a visit to the emergency department for dental pain. Emergency departments are not equipped to care for them, and it ultimately ends up costing the health system much more. And finally, let's take a look at quality of primary care delivery. This is one of the key factors impacting disease prevalence. This is an example of a part of the oral health section of the clinical indicator report. These indicators haven't changed since they were first established in 2000, but they only provide a partial story. Why did these patients return? Did a filling fail within 6 months, or was it filling placed on a different surface of the same tooth within 6 months? Did the dentist have poor surgical technique, or did the patient experience a common post-op complication such as a dry socket after the extraction? Was the denture remade because it was a poor fit, Or did the patient drop them or lose them? It's important to identify reasons for unplanned returns, which can only be found in the clinical notes. This can improve the accuracy of the numbers being reported and therefore more accurately reflect on quality of care. So in summary, because oral diseases are still ranked #1 most prevalent conditions, we need to pay more attention to how we could address this. And because high prevalence is affected by social determinants of health and quality of primary care, these are some areas worth exploring using clinical notes in electronic dental records. NLP research in dentistry is growing, but at a much slower rate than in other areas of medicine. Still, the quality of the clinical notes determines the extent to which NLP can be useful. If the notes are missing critical information, then I think that starts a whole new conversation about what should be recorded. Maybe if dentists could see that notes were being used for more than just medico-legal requirements and reminders to themselves, the note-taking behavior might change. And finally, automatically classifying the reasons for unplanned returns could improve the accuracy of the clinical indicators report. Thank you.
Thanks heaps, Hanna. It was an amazing presentation. I will first ask the questions from people who are here, if anyone has questions. Otherwise, I will ask people who are in Zoom if they have any questions. If someone has questions on Zoom, please just post a chat or just use the raise hand button and we will do that after that. Any questions from the floor? Suggestions, remarks? Yes.
Thanks for the presentation. It was great. I have a question about possibly the accuracy of what is extracted from the notes. And would you tend to believe that the notes are sufficiently accurate to make decision that is that you believe in your decision, basically? So it's all about belief in what you found. Thank you. I hope it's sufficiently clear.
Thank you. Did you capture that, Hanna?
Yeah, thank you. Thanks to the person who asked the question. I think it's a great question. And in terms of accuracy, so what is recorded at the time of the encounter, I believe to be accurate. The problem is that there appears to be a lack of an update from encounter to encounter, and that's what's creating a bit of a challenge. The other thing that you mentioned in relation to accuracy, which actually I'm happy to throw this out to the audience and ask, where one of the problems we're currently facing is with annotation. So annotating clinical data is expensive, it's hard to find the right people, and yet it's a big chunk of the work. And one of the things in annotation is making decisions from language that's very ambiguous. So that makes it very, very challenging. So if anyone's got any ideas on this, I'm all ears.
Anyone got any suggestions?
Well, I have a suggestion which is really for the future rather than for the analysis, which is that an app that actually collected the notes and prompted people and made it easier with shortcuts and checkboxes and things like that might help you capture the information up front rather than depending on dealing with obscure notes.
Like a chat question. Do you have anyone on Zoom asking questions? If not, I think I do have one suggestion because I used to flat with two orthodontists and they just keep taking photos of teeth and they start judging me how my teeth, my face looks like. But this is just a suggestion, Hanna. It's like, have you considered using multimodal where you have like, I mean, I know dentists, they just love taking photos of the teeth, about the whole dentures and everything, and then comparing it with clinical notes, so at least we can find a standardized way. I'm not too sure if that has been done, like using a multimodal both from image and from a text perspective.
So there's a fair bit of work that's been done on imaging, but there hasn't been any work to date that I know of that's kind of combined text and imaging to the extent that it can be used in a clinical situation. I think we have a long way to go. And one of the things I just want to point out is that clinicians in general, whether it's dentistry or medicine, we like our stories and we like writing notes. And I think for us to adopt a model that's completely structured forms and that imaging data and no notes, I'm struggling to see a future in that, at least in the near term.
Right, thank you very much. Another round of applause for Hanna, please.